It is now my pleasure to introduce you to our first keynote speaker for the 2021 Dakota Conference, Dr. Joshua Wynne. Dr. Wynne is a senior physician executive with strong leadership, academic, and administrative skills and extensive experience in multiple aspects of academic healthcare systems, including the provision of clinical services, the development of research and academic enterprises, and the delivery of first-rate teaching content and programs. In addition to his medical degree, he earned his Master's of Business Administration degree from the University of Chicago and a Master's in Public Health in Health Management and Policy from the University of Michigan School of Public Health. He serves as Vice President for Health Affairs and Dean of the UND School of Medicine and Health Sciences, and is the Chief Health Strategist for the state of North Dakota. He served as interim president of the University of North Dakota prior to the arrival of our current president, Andy Armacost. Dr. Wynne has indicated that will include discussion of commercial products or services, but neither he nor any member of his immediate family have a relevant financial interest or other relationship with the manufacturers of any products or providers or any services discussed. The presentation will not include any discussion of off-label or investigative uses of any product or services and will not include trade names. Thank you, Dr. Wynne. I'll hand it over to you.
Thanks so much, Kylie. Good afternoon, everyone. It's so nice to be with you. My topic relates to our virtual meeting, and that is the pandemic. And it obviously has had an enormous impact on all of us in North Dakota, but obviously around the world as well. There have been some unique both challenges and advantages, quite frankly, of being in rural areas of North Dakota. And I'll touch on some of them as we talk about the pandemic, what its impact has been, and what the lessons that we've learned from it. So what I want to talk about is North Dakota's COVID-19 response and the lessons learned. So what I'd like to talk about today is to go over some of the basic virology of SARS-CoV-2, talk some about its transmissibility, diagnostic and surveillance testing, mitigation strategies, role of vaccines, importantly, the pandemic in North Dakota, and what I see for the future. I'd also like to thank my colleague and friend, Dr. Paul Carson of North Dakota State University, for his partnership during this pandemic, and also for sharing some of his slides. So he's been a wonderful colleague, and I appreciate his help and some of his slides. Now, one of the things that has been important to notice about coronaviruses is their relationship between animals and humans. So this isn't the first coronavirus epidemic that we've seen. So there's been SARS and MERS before, and in both of those cases, there was an association, among other things, with bats. As you know from the news media, that there has been renewed interest in actually where SARS-CoV-2 came from. You see the question mark because we're really not clear. You know that there has been speculation that it came from a bat species. There was speculation that it may have spread in the food market at Wuhan. And then, of course, more recently, there's renewed interest of maybe that this was a lab accident related to the viral use in the Wuhan Institute of Virology. One of the interesting things is a very interesting paper that was in the highly regarded journal Science that was published a month or so ago that used sophisticated analysis to really show that the first likely human occurrence of SARS-CoV-2 occurred not in December at the food market, but it actually occurred in November. It's interesting then where there was this news report that allegedly 3 members at the Wuhan Institute of Virology became sick sometime in November. And there's speculation that maybe that's the way this pandemic started. The true answer is not known at present, and we may never know. But this possibility of transmission from more primitive animals certainly is a possibility. This is that paper in Science that I referenced. This is where they actually did a so-called molecular clock analysis, looking at the origins, looking at the actual genetic makeup of the SARS-CoV-2. And as you can see, the earliest cases they predict is either late October or early November. And they established the date of November 17th as the first time that they feel reasonably confident that it occurred. So it clearly was before the alleged outbreak at the food market, and where exactly it came from, again, is still not clear. Now, what do we know about this class of viruses? Well, coronaviruses are a large family of viruses. Some of them only infect animals and do not cause illness in humans, but others can cause illness in people as well. The common symptoms include mild respiratory illnesses like the common cold, but some viruses infect animals and then spread to people, and then, of course, very concerningly, there is person-to-person spread, and we now know that that has occurred at least twice before with the Middle East Respiratory Syndrome, or MERS, and the severe acute respiratory syndrome of SARS. And now, of course, we know that it's occurred with SARS-CoV-2, also known as coronavirus disease 2019, or COVID-19. The most important way that coronavirus is spread person to person is by droplets in expired air that, or from sneezing or coughing that comes from one person to another. Now, there are two other potential mechanisms that we are pretty sure are much less important. One is called the fomite route, that is by direct contact. Hence, you see a lot of people, especially in the past, with gloves on and so forth. We're pretty sure that fomite transmission is a much smaller concern than the droplet spread. There also has been a lot of interest in the so-called aerosol spread. That is, when the virus gets in the air and can affect long-range targets rather than the close contact that comes from droplets. Obviously, a lot of our approaches have been to try to reduce the droplet concern by doing physical distancing and the use of masks. Obviously, masks will also be useful for the aerosolization concern or the long-range transmission. Now, the very important issue for successful infection of an individual is how intense the exposure to the virus is and for how long. So the usual issues are to keep the amount of exposure as limited as possible and the time as limited as possible. So to limit the extent of exposure, we use protective devices like masks. We do a long distance between people, especially in the past, the so-called physical distancing. And the time duration is important too. The more exposure you get to droplets, the more likely you are to get the virus. Thus, if you recall in the past, there was a 15-minute window that was suggested. Now, again, there's nothing yes or no about 15 minutes, the importance is the longer the time that you spend closer to a person, the more likely you are to contract the disease. Now, you can see here on this slide that the way the virus is introduced via droplets matters. So a single breath gives you a few droplets, speaking gives you a little more, cough gives you a lot more, and a sneeze really gives you a lot. Thus, keeping your distance has made a lot of sense. So here is demonstrated the importance of aerosolization versus droplets. Here, person A is likely to infect person B because of the droplet spread, but at least over a short period of time, person C, quite a ways away, no exposure and has no chance of getting the virus. Over time, a lot of the larger particles you see down at the bottom in green will have settled, but person B inhales the particles, and person C still hasn't gotten any of the particles, but over time, person C could get some of the aerosolization. So here is an example of that, and the influence of humidity. The aerosolized virus does better in a lower humidity, in a higher humidity environment, and thus the droplets do better and therefore are more likely to fall out. On the other hand, the aerosolized particles may continue further away. Now, we know that the aerosol route can occur, and that's why filtering the air can be particularly important. You may be aware that the high efficiency filters, so-called HEPA filters, that are used in airplanes and in other settings actually are very efficient in getting those aerosolized particles out of the air and reducing the spread through the air, although direct spread close to an individual still could occur. Now, early on, we were concerned about the fomite spread, that is the spread of the virus on surfaces. And as this slide shows, one of the important aspects was the type of surface that it might have been on. So cardboard, you see a reasonably rapid fall off in the number of viral particles, whereas it tended to persist longer on plastic or shiny objects. Now you can see that studies have shown, at least in the laboratory, that the virus can survive from 2 hours to 9 days, depending on the type of surface, ambient temperature, and humidity. And more recent studies have shown marked viral decay after about 72 hours. So based on this slide, yours truly, up until recently, would isolate and put in quarantine our mail that we got delivered, and I put it in quarantine for 3 days. So every 3 days, I would look at the mail from 3 days prior. More and more data have indicated that this mode of transmission is pretty darn uncommon. So I'm about ready to stop quarantining our mail. My wife has been after me to do this for quite some time, and I think I'm about ready to agree. Now, indoor transmission of SARS is vastly different from outdoor transmission. Thus, if you recall, the the CDC guidelines, as well as UND guidelines, made an important distinction that has become even more important over time of indoors versus outdoors. So let's look at some indoor cases. So there were a wide variety of outbreaks in China with 3 or more cases. 80% were in the home, 34% were in a confined space, such as in transportation, a taxi, a car, a bus. 6% were in a food or entertainment venue, but outdoor exposure resulted in only a single transmission of one person to another. And this has been sustained over time, that outdoors, because of the much greater ventilation, results in a far lower risk of transmission of the virus. Now, one of the important things that we talked about was the intensity and the duration of exposure as to whether transmission occurred. So one of the measures of transmission is whether you can culture the virus. And here are some studies looking at, pardon me, the ability to culture viruses as a function of time and the number of particles, a number of viral particles. And on the left side of the slide, you can see that over time, a person who had the virus becomes much less likely to have a culture positive, because over time, the number of virus particles decreases very dramatically. On the other hand, on the right side of the slide, you see that the more viral particles you have, the more likely you are to have a positive culture, pardon me, for my allergy, and less likely to actually transmit the virus. So time and intensity of infection are important. And here is showing somewhat similar things. On the right side, you see the culture positivity versus days from onset of symptoms in someone who is positive with COVID. And as you can see, after a couple of days, there's an extremely rapid fall off in the number of positive cultures that you can obtain. And by day 10 or so, it's almost unheard of to have a positive culture. There are some that occur, but it's uncommon. Hence, the duration in which we suggested isolation of people, excuse me, who had COVID. On the left side of the slide, you can see the culture positivity on the y-axis versus the so-called CT value. Now, the CT value, or cycle threshold, is a measure of the most common test that we use for COVID, the so-called PCR test. And the higher the CT value means the fewer number of particles basically that we have. And as you can see, as the cycle threshold levels get higher, the culture positivity gets lower and lower. Pardon me. So that helps explain and inform the protective measures that we've suggested. Try to be outdoors, keep as great distance as possible, wear a mask, wash your hands to the extent that you might transmit the virus to your face, and stay away from activities like cheering at an indoor sporting event where you have a lot of people close together with a lot of expectorant coming out of their nose and mouth. Now, let's say you were unfortunate enough to get COVID. What are the sort of symptoms that you have? Well, the most common symptom is fever, followed by dry cough, fatigue, sputum production, shortness of breath, sore throat, and so forth. But we also see some people who have GI symptoms, including nausea and vomiting and diarrhea. Notice that fever is really important, and almost half the people on presentation had a fever. The rest developed it thereafter. Thankfully, the majority of cases with COVID are either asymptomatic or minimally symptomatic. The percent of people with mild or no symptoms has been estimated between 18 and 90%, and we really think it's closer to 90%. And people with clinical illness, especially severe clinical illness, is probably in the 10 or 15% range. As you know, the people who get into the red part of the triangle can have truly awful disease and, in fact, prolonged hospitalizations, prolonged stay in the intensive care unit, and a mortality rate in North Dakota that's about 1.5%. Now, this shows you some of the things that we've learned about hospitalizations, and notice the big difference in age-adjusted hospitalizations adjusted by race and ethnicity. So whites tend to have the lowest overall hospitalization rate, with especially high rates for Hispanics, Black, and American Indian and Alaska Native, who are the highest overall, relatively speaking. So it's clear that that the risk of severe disease and hospitalization depends importantly on race and ethnicity. A common finding that we have found in COVID that you know about is the loss of taste and smell. In one particular study, they looked at almost 300 people who tested positive in Italy upwards of a week after they presented. And they asked them if they experienced sudden onset of altered smell or taste in the 2 weeks prior to the positive test. And overall, 2/3 of them had some alteration in taste or smell. In 50%, it was moderate or severe. In the remainder, it was light. What are the risk factors for those who really get into trouble? And it's interesting, and I think you've heard about some of these. Clearly, as one gets older, as one becomes more obese, has underlying other conditions such as chronic kidney disease, male sex, or a history of heart failure, all of those lead to increased risk of hospitalization, severe illness, and death. Of particular concern is someone who's over or at the age of 75, where there's an odds ratio of 38. That is, someone over that age has roughly a 38-fold increase in risk compared with those who are less. Thus, if you recall earlier in the pandemic, the devastating impact that occurred in extended care facilities where you had people with multiple comorbidities and they were elderly. And there, the outcome after COVID was awful, just terrible. So age is a major risk factor for hospitalization and death. Here it shows it as well, the increasing risk of the percent hospitalized as age increases. Now notice that younger folks, that is those under 50, while their rate is much lower than those who are over 65, it's not zero. So it isn't that younger people are immune to hospitalization, it's that their risk is much lower. And in fact, we've seen even children and teenagers become quite ill and even die with COVID. Now, the risk is very low, all things considered, but if it's your child, you can imagine how devastating it would be. One of the things that has been very troubling, unlike the common cold where we just get over it, are persistent lung abnormalities. On the right side of the slide, you see various CT scans of people who have had COVID and where it persists over time. The lungs are the black part of the slide, and your lungs really should be black. In C, in the back part of that picture, where you see all that white fluffy stuff in the lungs, that is not good. So you can see that all of these have various abnormalities. And here was one study that was reported that looked at 55 Chinese patients who were followed, almost all of whom had significant involvement of their lungs and actually had COVID pneumonia. At 3 months, at least 2/3 of them had persistently abnormal CT scans of their lungs. And similarly, another study of patients showed that a month after hospital discharge, more than half still had breathing abnormalities. So you've heard about the long haulers where people have persistent symptoms following COVID. Here is graphic demonstration of that concern. Now, I mentioned that the mortality rate overall in North Dakota is about 1.5%, precisely 1.4%. Here you see the dramatic escalation of the infection fatality ratio as age progresses. You can see that those under 40 have an extremely low risk. It then goes up a little bit more, but then really increases a lot in the more elderly. So that has been a real risk factor as we've gone forward. Now, one of the things that has been a concern, obviously, is when are people infectious? One of the problems, as you know, is that a surprisingly large percentage of people with COVID have no symptoms whatsoever. So you could be next to someone who looks just fine and they're shedding virus. This slide shows what a test result shows and whether someone is infectious. And what you can see is that it really is a function of the viral load. So before someone has a significant viral load shown in blue, all of the tests are negative. But then once that viral load still starts to go up, they have positive tests. Now there's a short window, as you see there in green, where they may be positive by the test, but they don't have a large enough viral load yet to really transmit it. But for the most part, if someone has a positive test it's early in the course of the disease, they're going to be infectious. Now, I just want to touch on that post-infectious phase where a person may still have a positive test, that PCR or polymerase chain reaction test. They still may be positive, but they may not be infectious because their viral load is low enough that they just don't transmit enough virus to another person to infect them, and yet their test is still positive. Now, one of the more common tests that we've used more recently is a so-called antigen test. The one that's used around here a lot is called the Binax Now test. And here is a study contrasting the Binax Now test with the standard or PCR test. And what you can see in blue are individuals who are culture positive, and in the black are people who are culture negative. And to give you the bottom line of these tests comparison, it's this: that the ability to detect the disease, that is the sensitivity of the test, the Binax Now test is pretty good in symptomatic people. It will detect the majority of symptomatic people who are culture positive and have a positive PCR test. On the other hand, it does not do as well in asymptomatic people, where you still could pick up the disease in asymptomatic people with the PCR test, even though the BinaxNOW test is negative. So what I like to say about the antigen test, like the BinaxNOW test, is it's a good supplement for the PCR test. I would prefer to not replace the PCR test because, as you can see at the bottom of the slide, the PCR test in the culture positive environment does better. The BinaxNOW test is not as good, but a BinaxNOW test is certainly better than no test at all. I'll give you an example where we use this to advantage. A couple of weeks ago, we had a commencement exercise for our graduating medical students, and they wanted to have some in-person event. So what we did is we had a hybrid event where families and friends attended virtually, as we're doing now, but the students were there with me and President Armacost in the Chester Fritz Auditorium on the UND campus. But one of the things we agreed to collectively is that all of us underwent BinaxNOW testing just prior to commencement. And fortunately, all of us had negative tests, so all of us got to attend commencement. But there's an example where we would not have been able to do PCR testing because it takes a day or two using the standard analysis method to get a result. The BinaxNOW test, we had a result in 10 or 15 minutes. So the BinaxNOW test is a good supplement to the PCR test. So where are we regarding face masks? Well, as you know, there have been face mask wars where people have been on either side, and it's become an ideological crusade on both sides. There's been a lot of relaxation of face masks. You know that the state of North Dakota has rescinded its imperative to wear masks. UND has changed it, but I still think there can be some role. So when I see patients tomorrow in clinic, in the clinic, I'm going to be in a mask, and all my patients will be in a mask. Because I see patients in our building on the UND campus, everyone will continue to wear masks. So why do we? What's the truth about masks? Well, Mark Twain had, I think, a very good comment about this. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. That's what gets you into trouble. So what do face coverings accomplish? Well, we know for the type of mask that I wear in the clinic, the so-called N95 mask, they really do work. The data are weaker on using other types of masks, but there are huge number of various studies that show that wearing any kind of mask diminishes expulsion of respiratory droplets that are infectious. And we know that from the prior slides how important that can be. Now, I had a variety of videos, but they didn't play well when I tested them. So I'm not going to show you the videos, but let's just, let me just show you this as a single example of what can happen with a simple cloth face mask. So here's a homemade face mask using a variety of layers of cotton, showing that a properly fitted mask where you don't have leakage from the top or through the mask really does stop particles from getting out. And you can see the slide or the display at the bottom showing the efficacy in stopping droplets in the laboratory, mind you, of a bandana, a handkerchief, a medical mask, or a stitch, quilt, and cotton mask at cutting down the transmission of particles. So there's, I think, no question that masks are beneficial, and now we just have to use them intelligently. And then importantly, the vaccines have made a huge difference in the pandemic. Unfortunately, well, the good news is about 46% of the adult population in North Dakota has been vaccinated and is fully protected. Unfortunately, that means 54% are not yet fully vaccinated. It's really important that we try to get as many people vaccinated as possible. And let me say something about Operation Warp Speed. Maybe not the best name for this, but it really made a difference. So what is the warp speed in the development of the vaccines? Well, the traditional timeline to develop a vaccine in the past has been 10 or 15 years as one goes through the exploratory phase, the preclinical phase, clinical trials, FDA approval, and manufacturing. What was done with Operation Warp Speed is that there was an accelerated timeline with overlapping phases and the so-called EUA, or Emergency Use Authorization. What's important to emphasize in this accelerated timeline is that none of the clinical trial or safety undertakings were shortened at all. Notice one of the most important things is the overlap of the review process and the manufacturing process. The government, under the Trump administration, made the excellent decision to basically fund the development and manufacture of the vaccines before anyone knew that the vaccines would be safe and effective. So we went ahead with the manufacturing on the hope that the clinical trials would bear out the safety and efficacy of the vaccines. Well, the testing did show that, and therefore we had vaccines available much earlier than otherwise. Notice that what was not shortened was the exploratory and preclinical or clinical trials phases. So the safety part of Warp Speed was unchanged from what we did in the past. What was shortened was the overlapping of the review and approval process and then the rapid manufacture. And here is the timeline shown for the development of a vaccine. For the first time in the history of civilization on Earth, a vaccine was developed, tested, and injected into a human in less than a year. So the first confirmed case of SARS-CoV-2 was reported in late December of 2019, and the first human was inoculated with the Pfizer vaccine on December 8th, 2020. Less than a year, that is warp speed. That has made possible the dramatic change in the pandemic's course that we've seen over the last couple of months. Now, 3 vaccines in the United States have received emergency use authorization, the Pfizer and the Moderna, both so-called mRNA viruses, and involve 2 shots, and then the Johnson & Johnson vaccine with 1 shot. There are others that are being developed elsewhere and are being used elsewhere, but the 3 mainstays are shown on the left. Now, the Pfizer and Moderna vaccines are what we call mRNA, messenger RNA vaccines. And these are a novel type of vaccine that has not been used before. But basically, they stimulate the body to make proteins against the spike proteins that you heard about that exist on the COVID-19 viral particles, and thus protect the individual from infection by that particle, by that virus. On the other hand, the traditional virus is the Johnson & Johnson vaccine that uses a so-called adenovirus vector. That is, some of the viral DNA from COVID is introduced into an adenovirus vector, and that is injected into the human, and then they make protective both antibodies and cellular immunity against the viral particles that are trying to invade the body. So how effective are the vaccines in clinical trials? Well, as this slide suggests, we've really gotten over the goal, by quite a fair margin. That is 95% efficacious in preventing disease, and even more effective in preventing severe disease. Now, what does it mean if a if a vaccine offers 95% efficacy? Well, if you look at 20 people who received the vaccine, that the people who have been vaccinated on the right side of the slide, only one will get the virus compared with what would have happened if they weren't vaccinated. But even that one person who gets infected is very likely to have mild or no symptoms. There have been some hospitalizations and some deaths in the tens of millions of people who have been vaccinated, but the risk of having severe disease or dying is vanishingly small, vanishingly small. So there is huge efficacy. Now, this slide I forgot to press the second part of it. 95% efficacy means someone who is vaccinated has only a 1 in 20 chance of getting any infection, compared with no protection in those who didn't get the vaccine. So vaccines make a huge difference. Now, that's clinical trial data. What about in the real world? Well, here is a study of more than 500,000 people who were vaccinated or served as controls in Israel. And as you may know from the news media, Israel has had a remarkable rollout of the vaccines, with a lot of people vaccinated. And this is looking relatively early. So you notice that here it's people who got 2 doses of the vaccine, and they studied them at 7 days after the second dose. Now, we usually want to wait at least 2 weeks. So this was relatively early. And notice in the real world, there was a 92% protection for a documented infection, a 94% of symptomatic illness, 92% of severe disease, and there were essentially no deaths. So they couldn't even calculate what the protection was, because there were no deaths that early on. Another big question was, do vaccines prevent transmission? So let's say that I'm vaccinated, which I am, and I get exposed to someone with COVID. I develop no symptoms, but could I transmit that to my wife? Well, here are some data showing that the effectiveness in preventing transmission is really pretty high. And as time has gone on, we believe that it's maybe even better than these numbers. So the answer to the question is, do vaccines prevent transmission? Well, I would say vaccines dramatically reduce transmission. Now, one of the concerns that we had and have are the so-called variants. So over time, there have been a variety of variants, and this slide on the left shows the particular change in the molecular makeup of the spike protein that is used to identify variants. And one of the concerns has been that these variants may be resistant to the immune response that vaccines produce. And what we know over time is shown on this slide, which is sort of, if you are a movie fan, the good, the bad, and the ugly. The good is that vaccines produce better immune response than natural infection, good protection against severe disease, and pretty good protection against the variants. Now, the bad is that viruses like COVID-19, like coronaviruses, mutate. It's built into them, they mutate. So evolutionary pressure is leading to new mutants to appear. They're spreading quickly, are more infectious, and may be more lethal. Antibodies, that is what the body produces, appear to be less effective against the viral variants. The good news that we've seen over the last couple of months is that even though they're less effective, they still offer pretty good protection against these viral variants. So I would say that that we're still okay from the standpoint of the variants, but I would add the plea that all of you continue to work to get our populations immunized, because did I mention that these viruses like to mutate? And I don't want a really bad mutation to occur. What's the best way we can do that? To eliminate the reservoir where the viruses breed. Where do they breed? In unvaccinated people. So the more people we get vaccinated, we reduce the chance of variants appearing that might evade or elude the protective mechanisms that come from vaccination. The importance of all of this is something that we've known about. So the World Health Organization in 2019, as in before the pandemic, talked about 10 threats to global health. And what did they identify as number 8 on their list of a threat to global health? Vaccine hesitancy. So the concern even before the pandemic about people who refuse or are hesitant to get vaccinated was true even before the pandemic occurred. So hesitancy is on a wide spectrum. Now, let's hope most of us on this call are in the I'm ready phase. We've already been vaccinated or we're getting vaccinated. And at the other side is the refuse all. I don't trust vaccines. We're probably not going to be able to move the people all the way on that red ball a huge amount. But look at the wide variety of responses where we can influence things. On the left, accept but unsure, reassurance will help there. In the middle, there's some, I don't know, I have doubts. Here, people who are role models, people in the community, people of the same race or ethnicity can really make a difference. Arguing does not make a difference, but having someone that a person trusts who has a discussion about this can help to reduce hesitancy. Now, look, in North Dakota, we've been practicing physical distancing since the state was founded. So we know about keeping distances. So what have we in North Dakota learned from our response, and what are the lessons learned? So what we've learned is North Dakota's public health infrastructure was indeed better developed than in many other states. but we did find that there were major coordination challenges between the North Dakota Department of Health, local public health units, healthcare providers, and the public. So I think one of the things we've learned on the public health side is we need to involve each other more so we get better buy-in of all of the aspects, community, government, providers, so that we work better together in a more coordinated way. The mask mandate was temporally related to a dramatic decline in cases. Now, the mandate became politicized, but if you look at the actual curves, and I don't know if it was cause and effect, but cases declined dramatically once people started wearing masks. But here is something that a phrase that I've come up with that I think shows a little bit of maybe my cynicism, but it's something to think about. So people who don't really need to wear masks tend to wear them. So I'm vaccinated and I wear my mask a lot. And those who really should wear the masks, like people who are not vaccinated, tend not to. We need to get across that divide, because let me tell you, I've done the arithmetic. If you look at the percent of the population in the United States that's vaccinated and what expressed preferences are of who wears a mask and who doesn't, it turns out that the majority of people who are vaccinated intend to continue wearing masks in appropriate settings, and the majority of the people who are unvaccinated are not going to wear masks. So I did the arithmetic, and it turns out if you see someone walking down the street in America, not necessarily North Dakota, but walking down the street, the odds are that they are not vaccinated if they don't have a mask on. So when I did the calculation, 70% of the people walking around who aren't wearing a mask are in fact unvaccinated. So vaccine hesitancy remains a concern. How are we doing specifically in North Dakota? Well, I updated this when I prepared the slides, and so they're a couple of weeks old and things are even better now. But this shows our active cases in North Dakota over time. You can see that we started climbing back in April and May, peaked in late November and early December, then decreased, a little rebound later in the year, and we're now continuing to head down slowly, albeit still with persistent positive tests, but better overall. Since I'm at UND, let me talk about the North Dakota University system. So here are similar data for the North Dakota University system. And unlike North Dakota, you see that in the university system, we had a second earlier peak right after students returned from summer vacation. You see that steep increase in September? That was students coming from all over North Dakota, as well as all over the country, back to the university system, causing a rapid increase in the number of cases. That didn't come from the community. That came from students coming back from elsewhere. We got that under control, only to have community spread in late November and December, just like the rest of North Dakota, occurring because of community spread. You notice now, especially that most campuses have had a dramatic decrease in the number of students. With the end of the spring semester, there are only occasional cases being found now. And this shows a similar thing. These are active cases in this year among students in the university system. And you can see in May that the numbers are going down and they're even lower now. So the good news is that a lot of this is due to vaccination. So in North Dakota, almost 600,000 doses of vaccine have been administered. And currently we're up to about 46%, not 44%, with up-to-date coverage. That is 2 weeks after the last dose. So the good news is 46% of the adult population is now vaccinated. Of course, the bad news is 54% are not. You can see that it is a function of age. So the vast majority of 80-year-olds in blue have been vaccinated, but look at the college age groups. In yellow, the 19 to 29-year age groups, it's only about a quarter of college student aged individuals have been vaccinated. Now, there are a whole bunch of new developments in closing. So the CDC issued new guidelines for fully vaccinated individuals in March, April, and May. And if I summarize all of them, the new guidelines allow a fully vaccinated individual to gather indoors or outdoors without masks or physical distancing, with some exceptions, and eliminates the requirement for quarantine or testing after contact with someone who has COVID-19, again, with some exceptions. So, in conclusion, what are the issues going forward? Well, I think there are three issues in increasing level of importance that potentially cloud the otherwise encouraging picture regarding the pandemic. The first is transmissibility after natural infection and vaccination. And we think that that is, as I indicated earlier, not a big concern. A somewhat higher concern is the potential impact of the variants. We know that some are more transmissible. We know that some are more virulent. And we know that there is at least a relative resistance to immunity, although at least after vaccines, it does not appear to be a huge concern, at least so far. But that leads me to the final great concern, which is vaccine hesitancy. The way we stamp out this pandemic in a major way is to get everyone vaccinated. So vaccine hesitancy remains a concern, and all of us, you especially out in the rural communities, need to work on this vaccine hesitancy thing. Again, here is the slide that I showed before. The good news is that the most vulnerable are vaccinated. There you see the 80-year-olds, but notice how the curves are plateauing over time, that we're not seeing, especially among the younger people, enough vaccination. So issues going forward, the key issue is, given these issues, the key issue is when to relax public health measures and procedures. And as I said, we're already starting to get back to normal as far as less masks and less physical distancing, but we're not completely out of the woods yet. And the way to do it is vaccination. So how and when will the pandemic end? Well, I think the end is in sight, but there are only four ways. One, the virus mutates to a more benign and or less transmissible variant. Hasn't happened so far. Highly effective medical therapy becomes widely available. Hasn't happened so far. Group immunity is achieved because most people get the virus and develop protective immune responses. Not a good approach in a virus that has a 1.4 or 1.5% mortality. Or group immunity is achieved because most people get vaccinated and develop protective immune responses. I think that what we're seeing is some combination of the above, which is the combination of people who've had the virus and are now at least relatively immune, and that may be as much as a quarter of the population, plus group immunity through immunization. So I think we're hopefully towards the end of the pandemic. The way we can get there faster is to get everyone who is a suitable candidate vaccinated. So thank you so much for your attention. And if there's any time, Kylie, I'd be glad to entertain any questions. Otherwise, I thank all of you for your attention.
Thank you so much, Dr. Wynne. We do have to get on to the next session, but we really appreciate it. There's a comment in the chat box that sums it up great. This is one of the most balanced, comprehensive, and easily understood presentations on this subject they have attended. So thank you very much and have a wonderful afternoon.